All right, welcome to this explainer. Today, we're bringing high energy to a really structured, board-focused review of the Bartonella family. Look, if you're a medical student or a clinician gearing up for exams, you already know that infectious disease vignettes absolutely love to test the obscure, the stealthy, and the highly specific. And honestly, that is exactly what this rogues gallery of bacteria represents. We're going to break down the vectors, the clinical presentations, and those must-know treatments so you can confidently crush literally any question they throw your way. So, to start us off, I want you to think about this question. What on earth connects a playful kitten, a muddy World War I trench, and a sandfly buzzing around the Andes Mountains in Peru? I know, it sounds like the setup to a bizarre joke, but the punchline is actually Bartonella. This just perfectly highlights the incredible, vector-borne diversity of these stealthy bacteria. Each of these environments hosts a specific species, and knowing exactly which one goes where, well, that's your golden ticket to mastering this topic. Okay, let's dive into this syllabus. We're looking at 1. Family overview. 2. B. henselae, the feline threat. 3. B. quintana, the trench menace. 4. B. bacilliformis, Andean sandflies. 5. The culture-negative endocarditis mystery. And finally, 6. HIV manifestations and treatment. Starting right off with Section 1, Family Overview, a lineup of stealth pathogens. The absolute ultimate key to navigating clinical vignettes about this family is understanding the specific vector-to-disease link. Because while these organisms are all part of the same family, their clinical presentations vary wildly. I mean, you might see a patient with nothing more than just some mild lymph node swelling. Or you might be facing a patient rapidly deteriorating from lethal endocarditis or massive hemolytic anemia. The severity and the presentation depend entirely on the specific species, the geographic location, and, critically, the host's immune status. Moving to Section 2. B. henselae, the feline threat. All right, this is the culprit behind the most common board exam scenario you're going to face, cat scratch disease. Here are the vectors you need to know. First, bacteremic cats, specifically kittens. Second, cat fleas, which are actually responsible for the cat-to-cat transmission. Now, the classic exam trop is the actual mechanism here. It's flea feces resting on the cat's claws, getting inoculated into human skin via a scratch or bite. It's a remarkably specific mechanism, and test writers just love to use it. So in an immunocompetent patient, cat scratch disease is typically self-limiting. The key symptoms to look for include an inoculation papule or a pustule right at the scratch site, then regional lymphadenopathy showing up maybe 1 to 3 weeks later. You really want to watch for swollen axillary or epitrochlear nodes here. And finally, fever and general malaise in about half of these patients. But wait, what if it's not your typical presentation? And this brilliantly illustrates how the mechanism of injury dictates the actual symptom. If a patient gets eye contamination, say, they pet a kitten and then rub their eye, they can develop Paranoid's oculoglandular syndrome. This features granular matous conjunctivitis along with ipsilateral preauricular lymphadenopathy. Now, why preauricular? Simply because those are the nodes that drain the conjunctivita. It's this elegant, highly testable piece of anatomy and pathology perfectly combined together. Section 3. B. quintana, the trench menace. Historically, this is famous for devastating troops in World War I. But do not think it's just history. This pathogen is still highly relevant today. Here are your fast vector facts. Unlike our feline-loving first suspect, B. quintana relies strictly on the human body louse. Furthermore, humans act as the absolute only reservoir. There are no animal hosts hiding out in the background here. Today, you're mostly going to see this in urban environments among homeless populations or severe alcoholics, where, unfortunately, body lice can proliferate. When B. quintana strikes, it causes what's known as trench fever. Look for these exact symptoms in a vignette. Cyclical fevers spiking every 4 to 5 days, really intense leg pain, severe headache, and an enlarged spleen. Seriously, if you see that exact constellation of symptoms in a high-risk patient, B. quintana needs to be at the very top of your differential diagnosis. All right, Section 4. B. bacilliformis, Andean sandflies. We are totally shifting our geographical focus right now. The vector here is a very specific phlebotomine sandfly, Lutzomia verrucarum, and its habitat is massively restrictive. It's found almost exclusively in the high-altitude Andes valleys of Peru, Ecuador, and Colombia. So if a patient recently traveled there, alarm bells should be ringing in your head. And just a quick note, much like B. quintana, humans are the only reservoir here. Now, this little bug causes Carrion's disease. The acute bacteremic phase, which is called Arroya fever, is brutally destructive. The key symptom list includes massive hemolytic anemia, hepatomegaly, and jaundice, which eventually leads to vascular collapse. And because the immune system is basically shot during this acute phase, secondary salmonella infections are incredibly common. It's really vital to know that the untreated mortality rate for Arroyo fever can hit up to 40%. It's no joke.
Let's move to and see how this builds, because Cayenne's disease is uniquely biphasic. If the patient actually survives the massive hemolytic anemia of phase 1, Arroyo fever, the disease then evolves into phase 2.
Phase 2 is called verruga peruana, or Peruvian warts. Basically, weeks or even months after that initial fever subsides, the patient is going to erupt with these red, hemangioma-like cutaneous lesions. Test writers love, and I mean love, using this as a distractor because these lesions look visually similar to other angiomatous diseases. But that prior history of profound anemia and Indian travel, that is your dead giveaway.
Section 5. The culture-negative endocarditis mystery.
Okay, listen up, because this is literally one of the absolute highest yield topics in cardiology and ID, culture-negative endocarditis. Now, what's really interesting about this is how we contrast our two primary culprits. Bartonella, right alongside Coxiella burnetii, is one of the most common causes of this highly mysterious condition. So how do you actually tell them apart? Well, B. Hensley almost always requires pre-existing valvulopathy and a history of CAD exposure. B. cuntana, however, is uniquely aggressive. It attacks perfectly normal healthy valves, typically in patients with a history of homelessness or lice exposure. Make sure you cement this difference in your mind right now. I want you to burn the number 60% into your brain. Roughly 60% of Bartonella endocarditis cases hit the aortic valve. Furthermore, because it has this insidious, subacute course, and standard blood cultures often come back completely negative unless you incubate them for over 6 weeks, diagnosis is frequently delayed. As a direct result of that delay, roughly 60% of these patients will ultimately require surgical valve replacement. It's a slow but incredibly destructive process. Finally, Section 6, HIV manifestations and treatment.
So what happens when a patient's CD4 count drops below 100? Bartonella causes severe angioproliferative chaos. Here are the 2 key manifestations you need to memorize. First up, bacillary angiomatosis. This is characterized by tan, red, or purple non-painful cutaneous lesions, along with visceral and lytic bone lesions, and this can be caused by both strains. Second, bacillary paliosis hepatis. These are blood-filled cystic lesions specifically found in the liver, and this is exclusively linked to the feline strain, B. henselae. Fun fact, if you biopsied these lesions and use a Wirth and Starry silver stain, you would see the bacilli clear as day.
All right, let's talk drugs. We absolutely must discuss the rules of pharmacological treatment here. While you can use bacteriostatic macrolides like azithromycin to shorten the duration of simple cat scratch disease or even prolonged macrolides for bacillary angiomatosis, endocarditis is a completely different beast. Aminoglycosides like gentamicin are the only bactericidal agents against Bartonella species, period. If you are treating endocarditis, you absolutely must include an aminoglycoside for at least 2 weeks right alongside doxycycline. Before we wrap this explainer, I want to leave you with one vital clinical warning that will absolutely save you on your surgical rotations. About 10% of lymph nodes in cat scratch disease are going to suppurate. So, why must you never ever incise and drain them? Because doing so frequently leads to the formation of chronic, non-healing fistulas. You really don't want that. If a node must be drained, you always use a large bore needle aspiration instead. Okay, you now have the blueprints to the entire Bartonella family, but I want you to ask yourself, as climate change pushes these vector habitats further and further from the equator, how long will it be before these quote-unquote geographically isolated pathogens start showing up in your own local clinics?